So today we're going to discuss imaging the cervix in pregnancy using ultrasound and hopefully address some issues that we can call some helpful hints. When we think about measuring the cervix, we typically begin at about 24 weeks, and we can see there's a range here from the 10th to the 75th percentile, and the normal range is somewhere between 26 and 50 millimeters. The reason we choose 24 weeks is because that is more or less the cutoff at which a baby can be born after 24 weeks and survive, whereas before that time, most of these babies will not be viable outside the uterus. When we look at the cervix, as we can see here diagrammatically from Dr. Netter's diagram, the length of the cervix seen between this line and this line, measured that way. There are several ways to measure the length of the cervix. Certainly, the most common is the digital pelvic exam, but there are problems with using this. It's the most common, but it has anatomic problems. One is, as we can see here, the upper border of the vagina ends at this point here where the fornices are. So if you're doing a digital exam, you certainly can't palpate the proximal half of the cervix. It's a subjective evaluation. If you do a digital exam, you say, I think it measures so many centimeters long, but you can't take a picture of that. There certainly could be a risk of infection, especially if the membranes are ruptured. And even if they're not, if the membranes are coming down through the cervix, you could potentially rupture membranes. So it has a problem. If you compare the digital measurement of the cervix compared to ultrasound using a vaginal measurement, using vaginal ultrasound, we can see that on ultrasound, the length of the cervix is considerably longer than the digital exam. But that should not surprise you because, again, when you measure the cervix digitally, you're missing the whole proximal half of the cervix. So ultrasound is really the gold standard for evaluating the gravid cervix. There are several ways this can be done: transabdominally, translabially, and transvaginally. And we'll talk about each of these, starting with the transabdominal examination to measure the cervix, the most common way to do it, but the least accurate. Well, what are the problems with using a transabdominal approach? Some of it is a problem with the bladder. It could be too full, it could be too empty, and sometimes either due to an empty bladder or overlying fetal parts, the cervix may be obscured. So here's an example where the bladder is too full. It compresses not just the cervix together, but it drags the lower uterine segment, the anterior wall of it, against the posterior wall, causing it to look too long. It increases the measured length of the cervix, and actually the cervix is not that long. It's just compressing the lower uterine segment together. If it does so, as in this case, in the placenta, as we can see here, gets dragged along with the lower uterine segment, you could think there might be a placenta previa. So that would increase the false positive diagnosis of placenta previa. Well, how do you address this really from a practical point of view? Here's a lady who gets an A+ for filling her bladder. It's very distended, and it doesn't really look like there's any problem. Well, I would very much urge you to realize that ultrasound is not done in a vacuum. You need to have a clinical history. And in this woman, actually, she had recurrent miscarriages in the mid-trimester of her pregnancy. So this is not an acceptable view because we already said her bladder might be compressing the cervix. So in this woman, when we emptied her bladder and went on to the next way of looking at her, in this case a translabial scan, we can see that her cervix is entirely dilated. It was just being compressed by this full bladder, and between the calipers here is the endocervical canal. So she's completely dilated, and that was completely missed due to the fact that her bladder was so distended and compressed the walls of her cervix. But it was her history that was the clue not to allow us to stop the scan at this point when her bladder was so full. Having an empty bladder can also be a problem if it's too empty. There can be acoustic shadowing, as we see here, denoted by the asterisks, and there is loss of the acoustic window, as we can see. We just don't have a good window to work through. Now, why are you seeing the shadow here? Well, one thing is you may be scanning over the pubic bone, and you may be seeing shadowing from the bone. Another is with the empty bladder. There's an angulation problem here between the bladder and the fluid in the uterus, causing some of the sound to be reflected away from the transducer, and hence the acoustic shadow. So these are technical problems that can lead to problems. A completely empty bladder, as in this case, may be confusing. Somebody who doesn't have a lot of experience may look at this case and think, wow, that cervix looks entirely dilated, with this being the internal and that the external cervical os. And in point of fact, whenever there's a problem or you're questioning something like this, I think it's a good idea to scan the patient in a different manner. In this case, we went on to a translabial scan. We can see her her cervix is completely closed. The anterior versus the posterior wall, the endocervical canal here, completely closed. What happened here was when her bladder was totally empty, as we can see here, something has to occupy the space where the bladder was. And so what happens is her uterus actually becomes more vertical, and so does the cervix. So here would be the internal os, the external os. The endocervical canal is seen, it's a line in this position, and you really can't resolve it because you're looking straight down along its course. Coming in by a translabial, or if you wanted a transvaginal route this way, we're 90 degrees to the position of the cervix, and therefore now, here's the coming down with the translabial scan, we're pointing directly looking at the endocervical canal, and hence we can resolve this issue. Sometimes, again, acoustic shadowing is seen here, limiting our ability to look at the cervix. And again, the bladder's quite empty. Is there a better way we can approach this cervix? And the answer here is yes. And we see not an ideal picture perhaps, but certainly I can measure the length of the cervix here, internal, external os. What is the difference between these two scans? The difference is the transducer that I chose. On the first image, I'm using a large-faced curved array transducer, and here I am using a sector scan. A sector probe I can position better in areas of limited view. I can push against the baby's head, which we did here. Notice here the head is lower. By taking that probe and coming just over the pubic bone, pushing a little bit with it, getting the presenting cranium out of the way, I now have a better ability to look at the cervix. So I would like to make a pitch, if you can, if you have this transducer available, a sector, in cases where you can't see the cervix well and you're scanning transabdominally, change to a smaller face transducer such as the sector probe. See if you can manipulate things and get a better look at the cervix. What about this case? Again, using a sector scanner abdominally, it looks like the internal os is open, and people might say there's a dilated cervix at that point. But again, if there's a question and you're unclear, look at it from a different approach. Here again, we went to a translabial scan, and we can see that the cervix from here to here is measuring 34 millimeters, and it's normal. So what is going on in this case? Why is the cervix normal here, but what is the problem here? Well, people who have had experience quickly recognize that what we're dealing with here is a lower uterine segment contraction, either a contraction that may be resolving or one that's actually forming. And it has this typical keyhole appearance. If you could force yourself to look beyond that keyhole, here is the normal cervix. But I urge you, if you have a question, go ahead and look at the patient using an alternate approach. And by that I mean either a translabial or a transvaginal approach. So we've already mentioned that there are problems with transabdominal scans, but we usually get away with it. It's the most common way we look, but we've discussed some of the problems. As you're looking at the cervix transabdominally, I also would suggest you take dedicated images of it. Do some cone down views of the cervix, look more than once, particularly if a woman is having contractions, because when a woman has a contraction, the cervix tends to shorten and dilate. And that would be a time when you might see that it's not looking quite as normal as it did when she was not having a contraction. Have the bladder relatively empty, not too full, where you can compress the cervical walls together, and not too empty, sort of moderate. And very important in yellow italics, patient's history is critically important as to when you might want to go and do either a translabial or a transvaginal scan.